I am just having a belly laugh over here. For the first time, I saw the label on that guitar, the PrevMed label. Did you have anything to do with that, Jesus?
Not at all. That's not on me. I wish I had.
So there you go. Now we've got PrevMed labeled Spanish guitars while we're listening to our Spanish guitar music. If welcome, if no matter where you are in the world, good morning, good evening, good late night. We got an interesting couple of discussions today and next week. We're going to dive way deep into the insulin survey, the OGTT, and it's one of the two core studies that we do that you just don't see very often. You hear discussion about it, but you just don't see docs doing it. So OGTT tells us so much more than what doctors usually use in terms of diagnosing the thing that's killing us and disabling us more than anything else: fractured, broken carb metabolism. And you learn so much. Doctors today think that they're using hemoglobin A1C. And theoretically, so many things work in theory and then don't really work so well in terms of actual use. And A1C is one of them. If you go to I'm not making this up. At least I've got backup with some really well-credentialed groups like the standards committees for the AACE, American Association of Clinical Endocrinologists, say, don't use A1C for making the diagnosis of diabetes. Why? Because it's a hemoglobin test, and anything that impacts hemoglobin can impact this. Things like genetics, multiple different types of genetics, ranging from sickle cell to thalassemia to depending on which part of the world you happen to be from. Pregnancy impacts hemoglobin. Being a male versus a female impacts hemoglobin. Liver and kidney disease impact hemoglobin. So that's just the problem with hemoglobin. But as so many things, again, happen in terms of theory versus reality, if you look at the science, and that's what we do on this channel, we go deep into the science. What's the evidence versus the theory? If you look at the science, the real evidence about how diabetes is actually diagnosed, when it is diagnosed, it's usually from a fasting glucose that happened to be drawn when blood was being drawn for some other reason. Now, fasting glucose is, even your typical doctor will agree, fasting glucose, most typical doctors, I'll back off on that, not all of them, unfortunately, even with the poor state of the art in terms of docs misunderstanding how to diagnose this problem, even most docs will understand that fasting glucose is a poor way to diagnose diabetes. Unfortunately, the evidence shows that's what most docs are using. If you think that I'm being critical of docs, I'm not doing that. I'm not doing that alone either. My peers at Hopkins first started pointing this out, and then Mayo, docs at Harvard, other purveyors of standardized academic medicine have pointed it out. 2/3 of primary care docs, and this is more than primary care docs. This includes family practitioners, internists, even cardiologists, because everybody tends to depend on these three groups for prevention of cardiovascular disease, which means more than anything else, prevention of diabetes. You look at those groups, and 2/3 of doctors don't know how to make the diagnosis of simple prediabetes, insulin resistance, the problem that's the most common. So if they can't even make the diagnosis, how are they going to manage it? So that's a little bit of a preamble. That's, if there's one thing that we do with this channel, it's helping people recognize that problem. And it's a huge problem. Everything has become political these days. Hopefully that will begin to slow down, but I apologize to those that don't want to ever hear me mention the CDC. I'm getting ready to mention them. Even the CDC says, look, at least a third of people that have this problem are underdiagnosed. Well, they're, like so many things, they're right, but they're also wrong. They're right in that this is grossly underdiagnosed. And they're wrong in terms of they grossly underdiagnosed it as well, because their numbers, where they say it's a third, they're just using hemoglobin A1C and fasting glucose to make that estimate. When you start looking at what we're talking about today, OGTT, and then even better, an insulin survey, you get so much more information and pick up another, 50%, depending on how you're counting and what your denominators are. So I was, Jesus and I were reviewing this before the show this morning. And again, I was making the point that it's, I can't believe it. It's such a core part of what we are about, what this channel is for. And I've really covered relatively little details on how you can interpret these studies. So again, thanks to Jesus for doing a lot of that background work, getting the data, organizing it. Today, we're going to cover more information. We started last week with some of the discussion about this whole urban theory that, you've got to do carb loading. If you don't do carb loading, some camps would say, you're going to see the artificial diabetes of starvation. Other camps, which if I were in one of those camps, I would have gone the other direction and been in the other camp that would say, well, you store up, your pancreas will store insulin. So that's part of what we'll talk about a little bit later once we get into the topic. Phase one insulin response. And you'll see some interesting results on a phase one insulin response on a patient that we saw yesterday that actually carb loaded once and then didn't carb load. We actually got the opposite of what you would think. So anyhow, we're going to talk a lot about that urban myth of carb loading and whether it's necessary and what kind of impact it might or might not have. And then next week, Jesus is going to go back, take a video that I did a couple of years ago, reviewing the book, The Diabetes Epidemic and You by Joseph Kraft. Then we're going to go deeper into the details. And I think what you'll see, don't want to leave cliffhangers here. I think this is such an important concept. I'm going to give my interpretation now, and then you can see, we'll go into the details and you can see where I'm drawing my interpretation. Again, the carb loading versus no carb loading, yes, it may have some impact, but nothing like the physiological problem of aging. We also talk about obesity, and it's really clear. Many patients and many people think that it's the obesity epidemic that's driving the diabetes epidemic. The reality is, yes, there are 3, maybe 4, but mostly 3 really big risk factors for this: aging, body fat, and genetics. Which of those can we actually change? We obviously can't change our age. We can't change our genetics yet, but we can change our body fat. So that is what creates a lot of opportunity for so many of us. As you can tell, I'm passionate about this topic. I'm excited about getting into it, But let me go back and do some orientation for the rest of the show. If you've never been on our show, what we're talking about is the things that really kill people and disable people. And more than anything else, it's failing carb metabolism. And as you might have picked up over the past 5 minutes, it's failing carb metabolism associated with aging. The tragedy here is we can take 95% of that risk off the table, most of it with lifestyle alone. But there are other things that we can do as well. Medication, supplements, things that I don't know that we're going to get into today because we've got so much content that we want to cover that Jesus has served up for us on the slides in terms of just how to test for it, how to interpret the tests. So we're going to be talking about that. That's the core of our channel. But we've got a lot of other things to talk about as well. You know, today we're going to do a short topic on E. coli infection. Why would we cover that? Well, as many of you know, we've gotten into a deeper primary care practice. As we've opened up for Medicare, the program has been very successful. We've got a huge waiting list now. And right now, what we're trying to do is just manage the demand versus continuing to manage our quality, our access to patients, and how we provide the best service. So we'll talk a little bit about that in the intro as well. Another short topic that we're going to cover is omega-3, back in our core area of cardiovascular prevention. But the reason we're talking about E. coli is we'll probably cover some primary care items off and on. We'll continue to do that. One of our patients ended up had done some travel and ended up having a Shigella toxin E. coli infection. And it's just a little bit of a warning for folks. We'll talk about that. Previous topics, examples of things we've covered: fasting and anti-aging drugs, the effect on diabetes. We talked about things like sirolimus, and what are the other things that I kept having a senior moment about?
Sirtuins, sirolimus, and
Rapamycin.
rapamycin. We discussed resveratrol as well a little bit.
Right.
Yeah.
The big one that we covered was rapamycin. It was named by the island of Rapa Nui. That's the Westerners know that as Easter Island, the island with those big stone carvings of heads and faces on it. And there's a underculture of folks in the anti-aging community that have looked at rapamycin. They know that it impacts things like our ability to, our cells' ability to metabolize in a more healthy fashion. And there's a little bit of I don't know if black market is the correct term for it or not, but there's a little bit of a market for trying rapamycin as an anti-aging drug. We went way into detail on that recently. You know, there's an area that, if there's one thing that I'm at least as passionate about as failed carb metabolism, it's life purpose and lifespan. And believe it or not, there's very interesting evidence, hard to argue with, what we would call a dose response curve in terms of your focus on what's my purpose for being here, and your ability to maintain health and lifespan. So if you've got a purpose for being, you're going to be longer. That's the simple version of that. And we go into the science in detail on it. If you're interested, go back and take a look. We had a visitor, Dr. David Wright, who's seen patients with us. He's done a lot of good work in the Bale-Dunedin community and with us. He came on and talked about some of that thing where, oh gosh, Peter Attia covered ApoB, and I got deluged with folks saying, hey, have you seen this? Have you seen this? And my answer was, yes, I've seen it. Did it provide a lot of new information? Some of his stuff had, but not this one. And it was like, we just needed to go ahead, grin and bear it, and move on. But David brought some really good information about the basics on ApoB. So that's the kind of stuff that you'll get with us. If you're not if you're more of a Locals or a Rumble person, we've got content on Locals and Rumble. If you have any interest at all in helping us get this information out, and you're a YouTuber or a YouTube focused person, join our YouTube channel. It helps us get that information out. And the information's making a difference all over the world. All you have to do is watch the comments for a few weeks and you'll see it. I wish, there are things that I can share, things that I cannot share in terms of the patient-doctor interaction. But one of the things I can share just generically is that, what do you think it is? Twice a week, 3 times a week that we get feedback that, Doc, you are saving so many lives out there. It's a big deal. So if you'd like to help us do that, join the YouTube channel. We'd appreciate it. I'm not going to talk much about the book other than to say, you know what, if you ever wondered why people like Tim Russert became the poster boy for, passed that stress test with flying colors and then died of a heart attack. If you ever wondered why that happened, this book goes into sometime bone-numbing detail, but a clear message on why that happens. And again, I'm not, I still haven't learned my lesson. I should compliment the book more. People have loved it and they've given us great feedback. Hey, Jesus, you want to talk a little bit more about the Medicare program and how that's working?
Well, I can tell you right now that the Medicare program has been growing a lot. There's a great team effort behind that. Folks that were working with the PrevMed team are doing a great job. And we on the last 2 weeks, I think you have seen more and more patients from Medicare. And we're up and rolling. And if you want to be part of that, you can just give us a call. I believe we still have the survey on the website, or you can just send an email at info@prevmedhealth.com, or just give us a call and we'll be happy to put you on the waiting list. There's a process, it's government insurance, so there's a lot of steps to go through, but believe me, it's worth the effort.
It's very interesting. We actually got our first dollar back from Medicare this week. Prior to that, it was, I was paying salaries for folks like Jesus and the rest of the team doing Medicare and hoping that at some point they would decide to pay us. They did pay us. They didn't pay us at all for any of the CCM program. And that was like, oh my gosh, typical bureaucratic challenge. And we got, if there's a bigger bureaucratic challenge than dealing with Medicare, it's dealing with the billing companies that deal with Medicare.
Yeah.
If you think my hair is white now, wait until we continue to go down that path. We're going to continue to do CCM. It's the right thing to do for patients. It is where prevention and all of medicine should go in the future. It's a great way of connecting the doctor's office team to the patient, and specifically continuing to generate focus and attention around lifestyle related issues, because you can't out prescribe, you can't out stent, you can't out bypass, you can't out supplement a lifestyle problem, and you can't outrun a diet problem. So it gets into a little bit of detail. So one of the things we're doing is describing this to patients as they start getting into the Medicare program. We got a typical response yesterday where the patient listened for a few minutes, and then he said, he gave us this look. He said, well, okay, send me the information. I knew that something was going on. And then he said, I just don't know. I think my lifestyle is tuned in, and I can't give you that level of information every day. And then I said, hey, wait a minute. He that lives by the sword shall die by the sword. I'm a patient as well. And I fill it out every day. I don't recommend doing it every day. I recommend 3 days a week. But it takes me less than 1 minute. My health, if anybody knows this stuff, I feel like I do. But it's also, it has helped me. It has helped me to go ahead and get reminded, hey, did you do your belly circumference? Did you do, are you watching your carbs? Are you taking your meds as you need to? Are you working out? If you're watching your carbs, how many are you eating? I get that reminder every day. I answer it. It takes less than a minute. And it's like that old Listerine commercial, the taste you hate once a day. So anything else in terms of Medicare?
Well, and I have this experience of mine that you just had about you were going to have an annual wellness visit elsewhere as a patient, and they just didn't show up. So
Oh, really?
and we are showing up, and we are following up on people, and we are a telemedicine based a practice, so you'll have some struggles with technology once in a while, but other than that, I think we're very happy with the progress, and I think we're really helping a lot of people that otherwise won't be able to get to see you and talk to you.
So Jesus is referring to my own personal care. And here's the story on that. Despite the fact that I got involved in Medicare fee for value, gosh, maybe pushing a decade ago, I was the chief science officer teaching doctors how to discover risk in patients metabolically. What we do is we discover patient health risk when it's just impacting the metabolism before it causes tissue damage. So, for example, if you look at the real science behind diabetes, by the time diabetes is diagnosed, between 1 and 2/3 of patients already show damage in their eyes. So that says two things. The first thing is that we wait way too late to diagnose it. It's underdiagnosed. And number two, that damage happens when you're pre-diabetic as well. This is not, oh, I got a touch of sugar and everything's okay until I get a diagnosis of diabetes, which unfortunately most docs tend to propagate. So that's what I do. Now, I've done that for a large company. As I've shared with you before, we started our own company in Alabama. It was a great 2 years of focus with that group. We actually took on investors, and it was that large company. So it grew a lot bigger than we were. Their financial components, and it needed bigger strategic investors, and got it. And the program's just going great guns. We were at 3,500 patients when I took on the investment. Now it'll be pushing over 10,000 by the end of the year, helping 10,000 Alabama citizens get better health. So that's exciting. Now, what Jesus is referring to is, okay, it's the cobbler's children have no shoes kind of thing. What do I do for healthcare? And the reality is, I am with Medicare Advantage as a patient. I couldn't take that on within my own practice as a patient because we weren't doing it. We weren't approved for it in January of this year. So I went with I think it was United, but it was a national. So here's the other thing. These things are still regional or local as opposed to national, except for this program that I took on. So I took this program on as a patient, and they called me a few months ago and they said, hey, you need to do your AWV, annual wellness visit. So I said, great. I said, and they're going to have somebody come to the house. And I said, okay. I said, you don't happen to do telemedicine? Oh yeah, we do that. We love that. So we'll set you up for that, because obviously I was very curious, because that's what we're doing now. Well, it came time. There were a lot of challenges in terms of scheduling it because there was a scheduling entity, then there we're trying to find the provider to do it, then the nurse practitioner, et cetera, et cetera, et cetera. And it came time to do it, and nobody showed up. And it was like, well, that's interesting. And I don't mean they didn't show up at the house. I had set it up to do their telemedicine style. So I went back and shared with my team that, hey guys, we think that we have some challenges in terms of our startup. These guys didn't even show up. So that's what Jesus was referring to. I, in fact, just got a text a few minutes ago with them trying to reschedule. So telemedicine it's not a thing of the future, it's a thing of now. And again, we all think we think we have our challenges. We're doing better than the big guys. So happy to hear that. If you're interested in having your own doc continue to work with you, but work more in the way that we do it, prevention style, finding these disease processes when they're still metabolic before they result in tissue damage. We've got a whole program for that. That's what I did for physician partners for years. I'm actually will be going to South Florida this weekend to help train their docs again. It's a labor of love. I love doing it. And I learn a lot from working with that team. We have a whole set of plans. One of the things that frustrated me when I did this for physician partners was they struggled. You know, it's a large, very robust, great company, but some of the entrepreneurial things, the small time entrepreneurial things like doing videos was a new thing. And it took a long time to get through their chain of command. I went ahead and set up an entire program for the Alabama project where we had information on demand for the doctors and nurse practitioners when they needed it. So if they were being an insomniac and wanted to relearn how to make an early diagnosis on diabetes, they had it right there at their on their computer anytime they wanted to get state-of-the-art information. So we have now reconfigured that. We've re-recorded these training programs. We've got a full set of learning programs for docs. We can help your doc, your nurse practitioner, do what we do, provide better preventive care, and actually survive far better financially while they're doing it. So full scripts, just a quick mention. I always continue to say, you can't out supplement a lifestyle, but there are times when supplements help. And we go deep into the science on supplements. We've done it many times. Some actually, as Jesus can tell you, it was a total surprise, but some of our more popular information is K2. And we don't know why, but we start doing a video on K2 and people start tuning in. So there's a lot of information that we have on things like methylation, K2. We have standards in terms of, we've gone through, we've developed the appropriate protocols for specific conditions like diabetes. And if you have an interest in taking a look at the right supplements for the right condition, go in, you can find that. You know, Jesus, what we probably ought to do is develop a slide where we show people how to get to that full script dispensary on the website. Okay, Jesus, you want to start with the science? And this one is an interesting item, and it's very important to me as a patient. I've shared with people, I've got not only full-blown diabetes, which never would have been diagnosed had I not been a nudge and a nerd and personally on this issue. I've also got atrial fib. Both of these are very, very common, very, very underdiagnosed. And there are strong research signals coming out now that EPA, omega-3s, might actually increase some risk for atrial fib. What does that mean? Maybe a little bit too early to say. Should we stop it? We'll talk about that at the end of this discussion. Why don't you go ahead and talk about the data, the evidence?
Sure. So this article was brought out by to us by Daniel Trevor, who a lot of people is asking about Daniel Trevor's book. I think that's on the works still on the final lap, I think. And this is an interesting article. This is not a randomized controlled trial. This is more of an editor's note, single author. But he's basically reviewing some of the evidence behind the relationship with omega-3 fatty acids and atrial fibrillation. So he mentions a couple of studies that might provide some information about it. And this was published on JAMA, one of the more important scientific articles out there. So he mentions that the strength trial, where they tested around 13,000 high risk patients who were taking 4 grams of EPA and DHA versus corn oil. And after 42 months, no one, there was no associated risk with atrial fibrillation in either of those two groups. Then he reviews the reduced trial, which included 8,000 patients, same formulation, EPA and DHA versus mineral oil. And after almost 5 years, there was a slight increase, 5.3 versus 3% increased risk on omega-3 fatty acids to develop atrial fibrillation. So a small risk increase after 5 years. There's another study, the OMEMI study. It included 1,000 patients, less amount of EPA and DHA, 1.8 grams versus corn oil, a little bit higher incidence of atrial fibrillation, 72%. And the vital rhythm study, which included 12,000 patients, way less EPA and DHA concentration of 840 milligrams daily versus placebo. And again, no increased risk of atrial fibrillation between two groups. So, a couple of studies might suggest that higher doses of omega-3 fatty acids might increase the risk of atrial fibrillation. The mechanism is not clearly understood right now, but I think the evidence is not quite there yet. Not so much to say that there's more risk on omega-3 fatty acids versus the benefits that are behind them.
So I think I heard, with patients and with folks on the YouTube Live, we go through a lot of detail, and then they say, "Okay, I got all that, the back and forth." And I actually had a cousin tell me once. He said, "You sound like a politician." He said, "Just tell us whether to take it or not." And well, I haven't done that in a lot of these. I just talk about the evidence, but I'm getting more and more to where I'll say, what would I do? I'm still taking my omega-3s. Am I taking Vasipa? No, I don't have, I don't take Vasipa unless, or use Vasipa unless I have somebody who's got triglyceride levels like 150, 200. And most of the time, the vast majority of the time with those high triglyceride levels, I manage it with low carbs. But there's a place for medications. And yes, I do use Vasipa. But why do I go down that bunny hole? Because Vasipa it's a prescription drug, and the whole idea behind Vasipa is to take out DHA, take out all the other omega-3s, and just have concentrated EPA. Now, do I think there's a major hazard here? Do I think that we should stop taking omega-3s? Not at all. I'm still taking omega-3s. And if you have further questions about what I think the practical implications are for this data, this evidence, let me know. Okay, Shiga toxin. It's like, again, why are we going into that? Because we're going into primary care, and we'll be covering interesting primary care components. If you've traveled recently and you've come home with some diarrhea, there's a whole bunch of different things that might be associated with it. And one of them is E. coli. We had a patient that has been suffering from chronic diarrhea. The speaking of the chronic care management, the CCM program, that's how she kept us posted on what was going on. One of the questions in the CCM program on a daily or 3 times a week basis is, hey, do you need somebody from the doctor's team to call you? And that patient said, yep, I'd like to hear from somebody. And it was about this issue. So we got deeper into it. James started having some discussion with her. He needed me to get involved. I got involved. We started doing some treatment items, and this is what we ended up with when we ended up doing a culture of this this problem. The lab reported it to the health departments, because the health department has reporting requirements of labs. And anytime you have a Shigella toxin, or it's also called Shiga toxin producing E. coli, they want to know about it. They want to be able to track it. There are also some specific antibiotic therapy components that you want to use, specifically rifampin and
rifaximin and Cipro.
Yeah, I'm sorry. I should have just let you do that anyway. Rifaximin and Cipro. I remember when we were working with that patient, we were talking to her about, one of the items on the differential diagnosis is, do we have C. diff? You may have heard of C. diff. It's short for Clostridium difficile. It's a type of bacteria that causes diarrhea, and it's incredibly resistant to most antibiotics. And this patient had a couple of courses of antibiotics already. And that's one of the things that your provider needs to be thinking about. Usually, the vast majority of time for frontline first episode diarrhea, you should not use any type of antibiotic. It just makes it worse rather than better. Any other comments about this case, Jesus?
It usually goes undetected. I mean, you can have this and just have a couple of episodes of diarrhea, and it's self-limited, usually. But sometimes it can create a set of problems, and it's not E. coli can produce this toxin. Actually, we have E. coli on the stool all the time. That's their native place of an E. coli bacteria to be in. That's why it's so important to wash your hands and keep those hygiene measurements all the time. But sometimes there are E. coli that produce this toxin and that have all this stuff going on, and you can have lower levels of bacteria that they don't even show in the culture, but you have the toxin out there, and that is the toxin that is producing all this stuff. Now that you mentioned Clostridium difficile,
easy for you to say.
Well, it's related. It's a Spanish related word, because difficile mean difficile in Spanish means hard. It's
Right.
difficult, and
In
it really
Castilian,
is a
it's
problem.
difficile.
Yeah,
Sorry, go ahead.
it's difficult to say as well. But yeah, it's honored by its own name, because it's a hard stuff, and it's related to misuse of antibiotics. So just be careful about that. This Shiga toxin, also treatment about this is on research as well. There are antibodies for that, but they're not ready for prime time yet.
So speaking of prime time for our channel right now is going to be talking a lot more about low carb. Well, talking about people in our very common and very underdiagnosed challenges with aging and carb metabolism. And again, the goal here is that since it damages tissue so much, pardon me, but I'm going to continue to go off on a little tangent or rant here. Number one cause of blindness, number one cause of erectile dysfunction, which is very important. As I age, it becomes more important, more and more important as a priority for me. It's a big deal for men in terms of lifestyle. And again, I won't go down that tangent, but number one cause of kidney disease, and number one cause of the kidney disease resulting in people going on full blown um, uh, oh, I'm having another senior moment. Kidney kidney failure, and having to go on the machine for kidney failure. Most importantly, the number one cause of heart attack, the number one cause of stroke, the number one cause of cognitive decline. So, all of that, this is an important issue. We're very passionate about it. And most of that risk you can take off the table. But you really need to know what you're dealing with. And that is part of the problem. It's not easy to test for this. It takes a couple of hours of the patient's time in the lab, and you can't walk around. You need to sit and watch how your body metabolizes carbs. If we've seen it once, we've seen it 1,000 times, and you'll see it on the evidence that we're going to show in just a minute. This over-reliance on fasting glucose is a great reason why this problem is underdiagnosed. Docs just wait to look at it on fasting, and fasting is often perfect in people that have full-blown diabetes. So if you'll give us the water bottle, we'll get into the topic for today. Okay, Jesus, take it away.
So we're gonna share something that we put as short content last week. Somebody sent an email to us a few weeks back and mentioned, "Hey, I think you guys never have talked about adaptive glucose mechanisms or problems." And they were putting the example of the people that has lean mass hyperresponder status, people who are on low carb diet and they see their LDL through the roof. And this person on the email was saying, well, I think that's something that happens as well with glucose, and I don't think you have addressed that in the past. We did cover this topic a few months back, I believe last year, but it was a good moment to revisit the evidence. And there's not so much evidence out there, at least not evidence that it's supportive of uh, of this phenomenon and that has good quality. One interesting article that we found was this one, where the expert consult was presenting the case of one person that they believe supported this idea. So they mentioned that with the increase of A1C for diagnosis, there is less and less OGTTs getting done out there. And even the AAC, the American College of Clinical Endocrinologists, have mentioned that A1C is not good for diagnosis, and still some people are using that for it. And the other thing that they are concerned about is that they say that there's a false positive risk of OGTTs when people are on low carb diets. So they mentioned that people who are on low carb diet can misdiagnose with diabetes. And they mentioned this case report as an example. And they mentioned that they saw a 20-year-old healthy woman as a volunteer, BMI of 20.7, no history of diabetes, and physically active. And they wanted to test if this phenomenon was really happening with her. So they tested a couple of times. They did some fasting glucose. Her fasting glucose was 71, and they wanted to do her first OGTT. However, this is what she ate the day prior of the OGTT. She ate a high carbohydrate breakfast, French fries for lunch, eggs, bacon, avocado, toast, and for dinner, and 8 ounces of orange juice. And when we first saw this and we see that table that you're seeing on the screen, we thought, well, they might have a point. But when we read that closely, we were like, well, I don't think that amount of food qualifies as low carb diet. They showed the results. The results were fasting glucose in 60, 30 minutes, 153, 1 hour, 153, 2 hours, 200, and 3 hours, 152.
Let me interrupt just a second. At
Sure.
most, it's going to go right over most people's head, just like it went over mine. So, what meal are they saying was low carb?
I think they were referring to the dinner, and they say 8 ounces
So,
of orange juice is low carb. But they didn't even consider all the food intake, including
so,
breakfast and lunch.
so they labeled French fries for lunch, avocado toast for dinner, and 8 ounces of orange juice as low carb.
Yep.
Can you believe that got published?
It's impressive. And
Amazing.
and, and last week you mentioned Giannitis. I hope I'm gonna mention that correctly one
Ioannidis.
day. One day,
Ioannidis.
I'll make it, and I'm gonna
Yeah,
throw a
one
party
day.
because of that. And we have a lot of stuff to mention about the quality of research and what is getting published out there. And something we haven't mentioned, and this is something that I have seen personally. I don't know if you have seen that as well. Just like in the news, sometimes you see headlines, right? And you
Oh
see
yeah.
you see news that they're quoting studies and they're saying that's the new thing.
Yeah.
So if this goes to a newspaper, how much of that people are actually going to see the evidence? How many doctors are really going to go ahead and read the article and see the evidence? And they're going to say low carb diet causes diabetes.
Yeah. Well,
And
you see that with that, you see a bunch of those with metformin already. You'll get these junior researchers that come out and they do this huge study. And it sounds huge because you may have tens of thousands of participants. And people look at that, they say, gosh, this is huge and this is a big problem. And it shows that metformin causes diabetes. And then you go back and you ask, okay, how did they do that study? And so here's what they do. They look at a large database of people and they look to see if they have diabetes or not. And they look to see the ones that were on metformin and they say, oh, wait a minute. The people that have diabetes were more likely to be on metformin. Therefore, metformin causes diabetes. And it's like, how can people possibly, what kind of referees do they have going on? And quite often you'll see they obviously don't have an active referee reviewing those kind of programs because it's like, how could you have done that? Back to uh, John, I think it's John Ioannidis and you on how most research is really bad.
that is correct.
Mhm.
And granted, to the point, they mentioned they showed these results to a group of experts on type 1 diabetes. So they saw that, they saw 200, and they said, okay, this looks like type 1 diabetes. We should do some antibody testing to verify that.
Because this lady was what? She was a young lady, 20
20
years
years.
old, BMI of 20.7. And then you see these numbers where she actually does hit a full 200 on her glucose at 2 hours. Now, it's interesting. You look at her numbers. She had a nice low fasting glucose of 60. She went to 153 at 30 and 60 minutes. And, it's interesting. It looks like she lost her phase one in terms of continuing to increase at 2 hours. That's what you tend to see with an older person. So already, that's really weird. The other thing that's really weird about these results is that they go back and they do this other OGTT on the quote high carb diet, end quote. And you get a 71 fasting and then a 75 at 2 hours and nothing at the 30 minutes, the half hour, the hour, or the 3 hours. So it's like, what do you make of that? You have any thoughts?
Well, it can be either bad design of not comparing the exact same results between first test and second test, or being with a conspiracy hat on. Maybe the results didn't fit their hypotheses and they just didn't include that.
Well, I think that both of those are reality, but I'm still trying to give them the benefit of the doubt. I'm thinking that they did do a test, and I'm thinking that's why this study actually did get published. Um, she's got dramatically different results here, even if everything is totally disconfigurated in terms of bad design. The low carb wasn't low carb, the high carb wasn't really documented. The same study was not done both times. They did two different studies, but there's significant difference in the 75 at 2 hours versus the 200. And one of the things that I wonder is, was she up and walking between the 0 and the 2 hour on that second test? Because you see that a lot, and you go out, people don't realize it. They think, well, I've got 2 hours to kill. I'm just going to walk around because, I'm following my health activities. And they don't realize that walking around alone is enough to do that. That's my suspicion, but no, they didn't cover that in the study. They weren't, again, like we said, the study was just interesting, but I certainly would not try to draw any conclusions about testing or physiology out of that quote study, end quote.
And the other thing, they neglected insulin survey. So whenever you have a oral glucose tolerance test and you only have glucose results, that's just half the picture. We don't know how their insulin actually behaved after the challenge.
And we'll see variation. We can see variation up to 20, even 30% sometimes, that goes up and down, which appears to be associated with cortisol and or lifestyle related issues. Matthew Walker talks about in his book, if you can have poor sleep for one night and have a significant increase in your insulin resistance for the next 48 hours. And we do see that. Rarely higher than a 30% variation. And you'll see some of that variation in the last case that we have on the last slide. We actually had a patient that's, a lot of our patients are really, really sharp. And one of our patients that we saw yesterday said, "Hey, docs, I know that you were doing this, and I did my own study. I did a carb load 1 year and no carb load on the other year. I'm not going to tell you which one because Jesus has it set up as a little quiz." And he had some significant variation. At the end of the day, I'm not convinced that variation wasn't either aging and or just the variation that we tend to see in these studies. But we don't tend to see that kind of variation. 2 weeks later, to go from a 200 at 2 hours down to 75, something else happened with this lady. And I don't know what it was. And they didn't put enough information in the write-up of the quote study, end quote, for us to tell a darn thing.
Yeah. Well, they're clearly believing they proved their hypothesis that it was the carb loading.
Yeah, well, if you see my eye rolling, I'm not going to deny that.
Well, at least they believe it.
Yeah,
and that's okay. So when you look for evidence on this topic, you have to go back to this New England Journal article. I know it's from the 1960s, but we haven't seen any other article that has a similar methodology. And this one, they were looking to determine the effects of lower levels of carb intake on an OGTT in non-diabetic patients. And they included, granted, this is a small study, they included 42 non-diabetic males. They received five test diets of 400 grams, 300, 200, and 100. For 3 days after that, they were given 100 grams and a 3-hour OGTT. So this is the World Health Organization OGTT methodology. They included 15 females. They received 3 test diets of 200 grams, 350 grams for 3 days, and the latest for 7 days. And the OGTT was performed after 100 grams of carbohydrates as well. So they tested with multiple amounts of carbs prior to the OGTT. And this is what they saw. So none of the 42 male volunteers met the criteria for diabetes after that. Only one male on the 100 grams diet met the criteria of possible diabetes. There was no statistically significant difference between them, and none of the 15 female volunteers met the criteria for diabetes either. So basically, this study, what it's saying is it didn't make a difference. Carb loading, not carb loading. Whoever has diabetes, and whoever doesn't, it doesn't. And more important than diabetes, because we get fixated on 200, 200 up for 2 hours or any time, or the threshold of 125, 126. But the reality is that if you do have insulin resistance, you don't have to wait until you meet the criteria for diabetes. That's just a number. If you have insulin resistance, you have pre-diabetes, you are on the same problem as if you had diabetes.
Same disease. So Jesus and I'll share some internal baseball with you. You know, Jesus, I used to control the slides. Now we set it up where Jesus can as well. And so we start getting into dueling slide control here.
Yeah.
I wanted to get back and make the comment that, yeah, you see some variation, but it's not enough variation to say, oh, like we saw in this case, she went from having full-blown diabetes to having nothing. We don't see that kind of variation on carb loads. And they saw some variation on carb loads, but they did not see this kind of variation to say, on one hand, you've got healthy metabolism, and on the other hand, you've got diabetes. That's just not what we see. So again, just to underline what Jesus is saying, this is not fantastic. This is not 7,000 patients. Here, where we're, let's see. This was 42. It was a randomized clinical trial. You could argue whether or not it was randomized. It was clearly a clinical trial. It was relatively small numbers, 42. So yeah, there may be some other answers out there. But that's by far the best information that we have found yet that talks about this specific issue. Does carb loading significantly change the results in somebody who's not eating carbs? Or does somebody who's restricting carbs, does carb restriction significantly change this? And again, I think the evidence that we have right now is that not really. It can change it a little bit, but how significant? Not very. One thing that we will do, we're not covering it this week, we're going to cover it next week, is the incontrovertible. I mean, you'll see it in the evidence, in the data. Diet may, no significant evidence in terms of changing, but age, it's the biggest issue. And people think that body fat is causing this epidemic. No, it's not body fat. Body fat's a big issue. It's the only issue of the three big risk factors that we can change, but it's aging that's causing this. We will go through the book, The Diabetes Epidemic in You. You read the book and you can read it in an hour or two. It's short. You can tell the author is new to authoring. He's not very sophisticated in terms of the language that he uses, but the evidence is just compelling. Every decade that we live, more and more of us have failures in our body to metabolize carbs. Anyhow, so we mentioned earlier that we had a case of a very interested, very talented, very smart patient who said, hey guys, I made the change. I did this myself. I did an experiment with an N of 1. I did 1 year my insulin survey with a carb load. And he and we knew he was on a low carb diet. Then the other year, I did not carb load. And I want you to, he went on to say, I'd love for you to present this data on your show. And Jesus and I were running from pillar to post. I forgot to ask Jesus to do it, but as you see, he not only did he did it, he added a neat little twist. He didn't tell us which one they carb loaded on. I wish we had one of those, those voting machines.
Oh, that will be wonderful. Yeah.
Yeah, and by the way, we could do a little of that. If you're looking at the channel and you want to make a comment, tell us which year. So Jesus, walk us through what's going on. It's 2022 on the left and 2023 on the right. Look at those numbers and tell us which year you think he carb loaded. Jesus, go ahead.
Yeah, and just a quick comment. So he was 68 years old in 2022, 69 this year. And we you have to consider this while you're thinking about which one could be the carb loading. The main discussion is folks who think are healthy and they're on low carb diet because of preventive reasons. They don't want to get diabetes. They think they're healthy, and they're the ones that think that having an OGTT will somehow create a false diabetes, or what the research called a lot of years back hunger diabetes, or starvation diabetes. So when you have a high genetic impact, and aging issues, well, you should expect to see some insulin resistance. And that's the first thing I want to point out. Independently on which ones this patient carb load, there is significant insulin resistance in both of them. So you see 2022 fasting glucose 82. If somebody just see fasting glucose on him at 60 years old, they're going to say, hey, you're okay. Let's see you next year. Next year, she's in with 79, and they're going to say he's healthy. He doesn't have anything. But once you do the OGTT, you see how this patient struggles to manage his glucose.
Let me
See,
interrupt and
sure.
just say what you said is maybe the most important part to all of this. If you look at the evidence, if you look at how doctors in real world are actually tracking this, it's with that fasting number. And as Jesus just said, this is a 69-year-old male who you can see from the second test, he clearly fits full-blown diabetes on the second test, and he's not that far away from it on the first test. And most doctors would have looked at his fasting glucose and said, you are doing great. Meanwhile, he's boiling his arteries. Thank you. Go ahead.
And I'm going to do something now that people are participating. We have some participation here that I want to mention. We have one vote for carb loading in 2023. Dennis is still thinking about it. E.T. himself mentioned carb loading on 2023. And Katie Ridgway mentions that her OGTT, the OGTT works in 2023, but insulin levels are not dissimilar, meaning they're very likely. And yes, that's a really good thing to notice. Even though glucose has been seen, we see a worse response in 2023. Fasting insulin 1 hour, 2 hours are very, very similar, meaning the insulin resistant issue is probably on the same severity that it was on 2022.
If I could interrupt again, Kathy, that's where I came from. I said, you know what? You've got the disease. You've got it a lot worse, especially look at the difference in the 2-hour number on those 2 years. So it's clearly worse in 2023, or at least the labs would indicate clearly worse in 2023. But if anybody thinks that either year this individual was safe eating a standard American diet, oh, come on. I mean, 1 hour after hour at 174, he would have been tearing up his eyes, his arteries, his kidney, only the places in his body where his arteries are.
Yep. So just drum roll here, and he did carb load on 2022. He didn't carb load on 2023.
Ka-ching. So I think most folks guessed where I keep confusing myself with my logic. Where was it that I thought it was 2023 as well, right?
Yeah, you thought 2023 was the year he carb loaded, but surprisingly, that it isn't.
Yeah.
And you might think, well, then it is true. If you don't carb load, you're gonna get diabetes diagnosis, and this is the key point. We're talking about someone who already has insulin resistance. You see that in 2022. Uh, there might be some validity on thinking that if you are not taking carbs so often, and then you have 100 grams of glucose or 75 grams of glucose once, you're gonna see something similar to what they described decades ago about dropping glucose on the urine and stuff like that. But it is not that meaningful, at least not if you have a high genetic component and aging. That's those are the main drivers, and we do know this patient has really important issues with genetics and aging.
So Rick Foley is, it's hard to take a challenge, but challenges are often the best learning point. So Rick's saying, hey, you guys are missing the point. The real question is carb loading required if the body is fat adapted and the pancreas isn't used to generating insulin on a keto diet, for example? Oh, I see what he's saying. He's saying, look, here's the assumption, and I think that's the assumption behind the other side of the debate regarding what I usually take. People assume, and I think Rick's assuming this, if you don't eat carbs, your pancreas forgets how to make insulin. And it's like, you're right, Rick. I am missing that point because I don't think your pancreas forgets. I don't think that your pancreas stops making insulin. I think what happens is the pancreas continues to make insulin, but it's not using it nearly so much. And it brings up the point about the loss of first phase. In older individuals, we tend to see loss of that first phase, which means that the glucose actually continues to climb from that half hour or 1 hour that you saw in the first one on that case study, where it continues. The second hour is even higher. But no, you're right, Rick. I am missing that point because I don't believe it. I don't believe the pancreas slows down that much to where it cannot respond to it cannot respond within a fairly immediate notice because again, bottom line is it has stored the insulin that it needs for an immediate response, and I don't think it takes hours for the pancreas to go back and say, "Oh, you know what? We need some more insulin." But
And,
anyhow,
and
Rick's making a great statement in terms of the other side of this debate and the theory behind it. Any
and
comments on that, Jesus?
I'm gonna say something, and that's gonna support the idea that I should control the slides sometimes. That's on the previous slide. So and if you see the results right here, at least this one case, this is somebody who we know, uh, proves that. See the insulin levels. It's not like they're depleted.
Oh yeah, really, really good point.
I
Look
mean,
at them.
it's one case. I know it's one case, but that's something that we can show right now, and I will say most of patients will show like this probably, but that's just an hypothesis of mine. And
But
see
that's
here,
but you and I see that over and over and over again. I mean, this is more than just a case example. It's expert opinion as well because we do this all day, every day, and we don't see you're bringing up a really good point. Given our world, we don't see. We do insulin surveys, and we don't see anybody's pancreas forgetting how to make insulin because they're on a low carb diet. I'm really glad Rick brought that point up, and I'm really glad we had this discussion because it now helps me understand what people are thinking. And no, it's not reality at all. You just don't see it.
That's an assumption, and I've been saying this for 3 weeks, but I haven't get to that moment. And I think next week is really gonna be a good moment to make a short slide about insulin and glucose metabolism, basic one-on-one glucose and insulin physiology, and maybe a quick slide on diabetes physiopathology, just to mention a little bit about this part of insulin metabolism. It's gonna be a challenge to summarize books on one slide, but we can try it. And see here, so these two are the assumptions. False positive, meaning you have diabetes if you don't carb load. If you don't carb load, your pancreas will not make and store any insulin, causing a false starvation diabetes result, which is basically what Rick is mentioning right here about being fat adapted and not using carbs, and therefore the pancreas forgets how to work, right? False negative. If you don't carb load, you will have an artificial high level of stored insulin, indicating less insulin resistance than reality. And this study suggests that neither of the above are true. Given the study design, the false negatives couldn't be ruled out. It's possible that you're having high levels of stored insulin that are not working correctly, but still, the evidence is not clear.
So this has been a very helpful conversation for me. And as you could see, it just there was no air in the windmills of my mind how people were thinking of that. And now, after Rick's comment and what you're bringing up, and Dennis Williamson's response here, your subcellular mitochondrial organelles migrate towards the fuel you're currently using. You burn what you eat, no question. And I talk about that all the time, getting patients to where they are fat adapted. I also talk about my own experience as well as many other patients' experience, to where you can make huge progress within just a matter of a couple of weeks. It's not like our body forgets how to do these things. We have the DNA that we were born with, and we can redevelop those proteins. But for many of us, it does take up to 6 months to get completely fat adapted. As you can see, I'm a big fan, a big focus on fat adaptation. But I never, because of what Jesus and I talked about, because of our experience in doing these insulin surveys on so many people on a regular basis that are low to no carb, it's really clear to me that our pancreas does not stop making insulin. That is really, really clear. Yes, you can be fat adapted. You can have the ability to burn fat, but don't assume that your pancreas forgets and just doesn't have insulin around. It just doesn't happen. Anyhow, other comments, Jesus?
And I think that's also the assumption related to saturated fats, decreasing insulin sensitivity. I've seen some studies regarding insulin signaling, and they have studied that, and they mentioned that maybe saturated fats, not monosaturated fats, but saturated fats can decrease insulin sensitivity, and it has to do a lot with that, the amount of insulin and the insulin efficiency or sensitivity.
Here's another interesting question. It's from Harvey Ops, and I'm still trying to wrap my head around this one as well. Maybe you can help us here. He's responding to Rick Foley, and he says, if the carb loading is going to take you out of ketosis, which it will for a minimum amount of time, doesn't it do it by releasing insulin? I'm not exactly sure. I mean, to me, I think the whole process of going out of ketosis is that you start eating carbs, or you start burning carbs again. You start having some insulin release. I'm not sure that I'm understanding the point or the question. Or do you get it, Jesus?
What I think is happening here is he's mentioning that maybe once you eat carbs, you're gonna see an increase on insulin. Like, I don't think Harvey believes that there's no insulin storage, and it's just a basic mechanism of eating carbs and releasing insulin. But when you say taking out of ketosis, I think it's just one of the things to mention, the release of insulin after carbs intake, but because there's also the mitochondrial mechanisms that get adjusted.
Right. I think you're going the same place I'm going. Going in and out of ketosis is multiple different items, only one of which is release of insulin. And the question almost implies to me that release of insulin is what creates the whole thing. No, that's not. I don't think that's the issue either. And Dennis is saying something similar, I think. Okay. Anything else on a great, great summary, great presentation, Jesus. I appreciate what you did, and great discussion about this. Anything else that we need to cover before we go to Q&A?
Well, and I appreciate viewers' patience and interest, because we sometimes do not take more than an hour on the long form content and all of that. But this specific topic was worth the discussion, and I thank you for your patience, for your participation. That means a lot. As you saw, when you do participate and bring up questions and comment, that makes this way more interesting. So thanks so much.
Okay. So if you'll give us the transition, we'll go into Q&A. We've got a lot more questions than we're going to be able to cover. I'm going to let you get started. We've got a new member, which we'll talk about in a minute, and as you're pointing out, we've got a super chat donation.
Yeah, two things. So I'm putting the super chats first, because if you wanna get your comment addressed by Dr. Brewer, go ahead and send us a super chat. That's gonna put you in front of the line, and or you can just send your question way before when the streaming starts. Bobby Ocampo knows about it. But
Not
see
that
here,
we would be entirely mercenary with our
no, not at
response.
all.
But if
No,
you
but I
want to
mean,
get,
it helps a lot.
it does. Again, as you may wonder where these dollars are going, and uh, the vast majority of well, none of this stuff ever gets anywhere near getting us beyond paying for our staff. We've got a lot of people who are helping us create this show and get this information out there. I'm not getting so many comments these days about the old shaky paper days. It was where I used to hold up. I didn't know how to do slides. I didn't know how to do any of that stuff. So I would, put something on paper and print it out and then hold it up. And I got pretty good. A lot of people complimented my talent on being able to point out something specifically on a printout. But those days are gone. We may do some of those one day just for old time's sake. But the point is to improve the technical quality. It takes money, and that's what this is. What these dollars go to do. If you would appreciate, we would appreciate you continuing to help us get that message out. It's all over the world. The reason we moved it up an hour earlier was there was a lot of demand in parts of Asia saying it's too late at night / early in the morning for us to get any kind of questions in, and we'd like to. So we did move it. So I think we've got a couple of them here. We had Tired Looking for Name Now. Great topic. Thank you, Tired. And LPG. Do we have any others?
I think those are the ones. Thank you so much. And thank you to new member Samier6. Thank you so much. Helps a lot.
I don't know if that's Samier or Samier, but thank you so much. Those that YouTube, you can join YouTube and you join it as a member, and it's like, what is it, $5 a month or something? And again, those dollars help us cover a little bit, but it's significant and helpful to help us get this information out all over the world.
Just going scrolling some of the salutes. Thank you so much. We see you every week. We appreciate that you're here. The CTBD, Bambi, Elizabeth, John Tocho, Rick Folia,
Just
um,
Rusty.
just Rusty.
Uh-oh, we're having some more
Go,
dueling.
tough work. Go ahead.
I'll back off. No, you're better at that than I am. You're in the generation. I just need to. We also acknowledge I'm the old man in the group, so I just need to enjoy being an old man and let the new generation manage that technology.
Yeah, you can go ahead and answer the tough questions. So sensitivity can't find answer among prior videos. Is nicotinic acid as supplement better than niacinamide? Also, is either supplement likely to make my tinnitus worse? Thanks.
On the first one, I have an opinion. As an old business, I learned a great quote from an old business partner of mine, James West. James has been on the channel many times, and one of his favorite quotes was, "He was often wrong, but never in doubt." And you see that a lot among people who are have enough temerity to put their opinions on a YouTube channel. Um, I have looked at comparisons on nicotinic acid and niacinamide. The bottom line is I don't think there's enough evidence to show either one as significantly better or more powerful. We've got a lot of information on nicotinic acid. We have a little bit on niacinamide, and that reflects, that's proportional to the information that's out there. So, niacinamide has that reputation as being maybe the natural no flush niacin supplement, but whether or not it's better, I think the jury's still out on that. Now, is either one likely to make tinnitus worse? I have tinnitus. I wish I knew the answer. I wish that the answer was known. And I also don't think that answer is known either. You have any comments about that?
Two comments. So I think there's some evidence that suggests that niacinamide, a little bit more than nicotinic acid, has some vasodilator effects, like opening the vessels. And some folks have studied that actually has to improve tinnitus, but I don't think that has been proven either. And do not confuse with nicotinamide riboside. And we
Right.
mentioned that a
Very
few
good
weeks
point.
back. Yeah, because nicotinamide riboside has been associated with breast cancer and other types of cancer. So just be aware of that.
I'm impressed. You did better on that than I did. I'll never admit it again.
I'm surprised as well. That means I'm learning a lot. I can tell you
You
that.
are. You're doing great.
Sembra Bashvan. Good morning,
Masiban.
Masiban. Good morning, Sembra. Thank you for joining us. I don't think I saw her before. I appreciate it. Thank you.
I don't either.
Jonathan Hall, good morning. Good morning to Katie Ridgway. Thank you for presenting this. Thank you for joining us. Eating himself, I was on methylated B complex for 4 months and did not notice anything different. All in all, should I have noticed something? I don't think so.
I don't either. Does anybody feel anything when they're a poor methylator? No. Do they, again, I always go back to, what is that guy's name? He's an internet personality as well.
Dr. C Doc. C
Yeah,
Doc.
Z-Dog.
C Doc.
And he's a what? Eastern European
I think so.
descent, Zacharias or something. So that's where the Z comes from. He does a lot of silly things like making, silly songs, but he's also got some good science. And he said, yes, poor methylation does exist. There's no question about it, but it's totally insignificant. Well, it is in his practice. He's an intensivist, and intensivist medicine is like the polar opposite of prevention. And the reality is, yes, it does exist. And yes, it does make a difference in terms of prevention, but it's nothing you're going to feel. You are never going to feel any symptoms. We also warn our patients where if they do decide, if they need to take if they are a poor methylator and they need to take methylated B vitamin complex, don't think that you're never going to get an elevated homocysteine again. That's not true either. You know, it's like everything else in this space. Oxidation state is multifactorial. So what you're trying to do is provide your body with methyl groups that they can use when you're getting into more of a higher oxidative state. You're not going to feel anything different, and your high homocysteine episodes are not going to go away.
Dave, the retired cop.
I'm not clicking on this thing. I just want you to know.
No, I know. I was waiting if you wanted to add something else, and I completely agree. I don't think you're gonna feel anything. Some people, and this might have something to do more with placebo effect rather than something else. But I have seen tons of patients that, let's say, they have full blown diabetes, right? And they are advised by their uh, neighbors or somebody to eat some supplement or some natural product. Have you heard of moringa before?
Oh, I've heard of it, but I can't remember. That's one of your favorite things, isn't it?
Well, I don't prescribe that. I don't recommend that. But moringa is a plant that has been called also the miraculous three, and always when someone puts miracle on it, I'm skeptical. So a lot of people take that because they think that that's gonna solve any insulin resistance and diabetes issue, and people feel better. They're like, "Oh, I'm taking this moringa thing, and I'm feeling better right now. I've been taking that like for 2 days, and they're all feeling better all of a sudden." And the reality is that moringa has been associated with kidney disease as well. So it's natural, doesn't mean it's safe. So to the point I'm going is, it might be some people out there that they think that they know they're pro-modulators and believe that some of their symptoms had to do with that, and they take methylated B complex and they may feel better. I don't know. Might happen.
It might. I just noticed. I'm going to give us a housekeeping warning. I have an event that I need to attend in 4 minutes. We've been going on a long time.
I know. Should we address
So
this one and wrap it up?
I will respond to this one. It brings up one of my favorite quotes, and that is, "Growing old's not for sissies." And it sounds like I'm being facetious. I'm not. It's the reality of things. So here, Dave, the retired cop, is saying he eats well, less than 20 grams of carbs per day, moderate exercise. His A1C and fasting glucose are climbing. And is he missing something? And the bottom line is, as we've said before, he's growing older. I don't know. I will make a bet that everybody watching this channel is growing older every day. And the point is, you start getting, that's where, no matter what you do to manage your health, one of the continued marches that we see, and especially depending on the genetics that you have, you can be managing your body fat very well, but still continue to go in this. My BMI was like 21 when I went into development of full-blown diabetes.
Yeah, and I will address the sleep as well. You need to see every corner that might influence that. And sometimes you need medication, sometimes you need supplements to help with that. And before we leave, I want to make honor of my word. I said super chats go first. I appreciate that. Wait a minute, silly. $11 super chat. It is it dollars? I think I don't know if those dollars, but okay. 47 years male, 5'10", 168, had a 10 year ago. Crestor, aspirin, metformin, A1C 5.4, triglyceride HDL radio 0.41, so that's really good. Oh, I think the triglyceride HDL is actually 0.56, ApoB, ApoA 0.41, so those are really good numbers. On low carb diet and exercise daily, CGM says high 6, low 7. Not sure what it means. How can I lower it?
Maybe he may be European.
Oh, and those might be on millimoles, right?
Yeah.
Well, okay, yeah. So 6 is above 100.
What's 7?
125. Yeah.
Okay. So then, could be a lot better. I mean, could be a lot worse, but could be a little bit better too. He's wanting to lower it. That's the bottom line. Well, it's like Jesus and I've said multiple times, lifestyle is king. You can't beat out lifestyle. I will say this, at a BMI, at 168 and a BMI of 510, a height of 510, you're probably what? BMI of 23, maybe 24. I would guess 20, somewhere around that time period, Yeah, you could, I'm 5'10", and I start getting more problems when I get up to the 170s. I just made it back down into the below 160. I've added a lot of muscle, so that helps. But that's one key issue. And I'll also add, I'm taking medications. I'm taking metformin, and I'm also taking a GLP-1.
And how much Crestor is he taking?
How much what?
How much Crestor? Is he in
Oh,
10?
I'm taking like.
No, but I'm saying for the viewer, because
Oh,
on paper,
it's a really good point. If he's taking, a lot of people are on like 20 and 40, and clearly that Crestor is going to make that go up. If it's at that level, 5 or less, like I'm taking, is not going to. But it's a really good point, Jesus.
and I will suggest reach out to us, and Dr. Brewer has patients all over the world. For any specific recommendation, will need to be through that route, not on a YouTube comment, but we can mention that just high doses of Crestor might have some relationship with insulin resistance.
We do. We have patients in Australia, New Zealand, Singapore, Thailand, Philippines, Brazil, Spain, England, the Middle East. We don't have any from Antarctica at this point in time.
Not any penguin with diabetes yet.
Thank you so much, Jesus. It was a lot of fun on the show today.
Thank you so much. Thank you for your patience, guys. We'll see you next week.
Bye-bye.